Welcome to the LifeStar EMS Training and Education Center. My name is Todd, and I'm thrilled that you're joining me today for a quick conversation about what I wish every nurse knew about EMS. This video originally began as a part of another project because one of the oldest and most prestigious nursing programs in the state of Wisconsin reached out to LifeStar and asked if we have room for their nursing students to do some clinical ride time on our ambulances. We thought this was a fantastic idea because over the 15 years that I've been doing this, I have noticed on many occasions a certain amount of conflict and misunderstanding and confusion that happens between nursing and EMS. Now that makes sense because there's nothing about nursing school that prepares you to work with EMS. You have enough to learn in that program, and you just can't afford the time it would take to go into the history of EMS and what we can and cannot do. So most nurses learn about EMS by interacting with us. If you work in an emergency department, you see us every day, so it's not a problem. You know what we can and what we can't do. But when you move to the ICU or med-surg units or labor and delivery departments or skilled nursing facilities, those nurses may not interact with EMS very often, and so that's where some of the confusion and miscommunication can happen. So this is not an exhaustive list. It's just my list of what I wish every nurse knew about EMS in order to improve that relationship. Let's start with the easiest thing. First, if you want to insult an EMT or paramedic, call us an ambulance driver. Now, I got to admit, if you Google ambulance driver, you're going to get all sorts of pictures of EMTs, ambulances, and paramedics. But we are not ambulance drivers. In fact, an ambulance driver is a level of license that doesn't even really get used in this state. Some other states still have it on the books. Some other states actually enforce those rules where you have to have an actual license to drive that vehicle. But ambulance driver is much more reminiscent of these guys. Back in the old days, when there was no EMS, it was the local funeral home's job to come and pick up patients and take them to the hospital because they had the only vehicle that was appropriate for carrying somebody who was lying down. The first ambulances that came out had ambulance drivers, and these folks could barely touch the patient other than to lift them up, put them on the cot, get them in the ambulance, and take them to the hospital. They were not medical providers. There are many levels of EMS licenses that have evolved. For each one of these levels of training, it requires that we go to school, that we take testing, and we obtain that license. So EMR, EMT, AEMT, registered paramedic, and critical care paramedic, these are all separate courses and separate certifications. So when we walk in the door and you say your ambulance driver is here, you're really negating and ignoring all the extra training and education that we had to get in order to achieve that level of license. On top of that, in between these individual levels of license, we may have spent months or years working the streets before we go back to increase our level of license. Now that I made a big deal about not calling us ambulance drivers, the truth is the origins of EMS really are in the transportation field more than the medical field. EMS as a field traces its roots back to 1966 when the National Academy of Science and the President's Commission on Highway Safety published what we refer to as the White Paper. The actual title of the White Paper is Accidental Death and Disability, the Neglected Disease of Modern Society. Now think about it. It's 1966. The interstate highway system has just been constructed. Cars are not nearly as regulated in the area of safety as they are today. And so there are a lot of accidents happening at higher speeds with cars that are not safe. And there's a lot of death and disability that's occurring. So this paper established the need for an emergency medical services in the United States. That same year, the National Highway Safety Act passed. It created the Department of Transportation, the National Highway Safety Transportation Administration, and it also provided funding for the first 300 EMS systems. Later on, as a result of this act, it also developed the first curriculum for what it takes to be an emergency medical technician. Later on, this would expand into what it takes to become a paramedic as well. And to this day, the Department of Transportation has a lot of say over what the curriculum for EMT and paramedic programs are. The fact that EMS began in the transportation field also means that we are highly governed by what's called cartage law or transport law. It is still a transportation business in addition to being a medical occupation, and for that reason, the laws that relate to sending a package from one place to another apply also to sending a patient from one place to another. Cartage law says, among other things, that a package belongs to the sender until it is received by the intended receiver. So you didn't think when you ordered that Amazon package and they put it on your front porch and some porch pirate comes and steals it, and then Amazon sends you another one, you didn't think they were doing that out of customer service, did you? It is good customer service, but the truth is the law requires it because that package was not stolen from you. It was stolen from Amazon. Well, this same principle applies to sending a patient from one place to another. When you send a patient out, that patient remains your patient until that patient arrives at their intended destination. Even today, we still refer to getting a patient ready for transport as packaging the patient. So cartage law still applies to EMS. Another difference between nursing and EMS is the initial education it requires to go into the field. Initial education is just the minimum education you have to have in order to get your license. I refer to nursing education as a mile wide but an inch deep. You have to learn a ton of stuff on a ton of topics. So you don't have time to go too deep into any one particular topic area. EMS in initial education I refer to as an inch wide but a mile deep. And the reason why is because in EMS, we are not generalists, we are specialists. What it really boils down to is for cardiac, respiratory, and trauma, and then about a dozen other topics like behavioral health and psychological emergencies, labor and delivery, endocrine emergencies. We do have to learn about that stuff too, because there can be pre-hospital emergencies that require immediate intervention. But for the most part, we are specialists, 1 inch wide, but a mile deep. So when it comes to pre-hospital cardiology, we get a ton of training in that area. For trauma, we are the experts by far for pre-hospital trauma and so on. So in the areas in which we specialize, we know a lot. And in the areas in which we are not specialized, we know next to nothing. Another thing you should be aware of is the importance of United States Title 42, which is called the Emergency Medical Treatment and Active Labor Act, or EMTALA. This is a central piece of legislation for EMS. In the beginning, EMTALA was passed in order to prevent hospitals from dumping patients on other hospitals by refusing to see them. And so what EMTALA requires is if a patient walks into the front door or is on hospital property or is within 250 yards of the hospital, that patient belongs to the hospital and the hospital must assess and stabilize that patient before sending them anywhere else. Well, through a bunch of administrative rules over the years, as well as court decisions, EMTALA has come to apply to nearly all transports of patients between hospitals. And EMTALA has criteria that have to be met in order for that transport to be legitimate. One of the interesting requirements of EMTALA is that a patient's paperwork has to accompany the patient during transport. And I provide the citation right here. What this means is when you are sending a patient from your hospital to another hospital, it's very common for an EMS crew to come in and introduce themselves and be told, you don't need this patient's paperwork or their medical history or their medication list, because that's all in the computer and the next hospital has access to the same computer system, so they already have it. Title 42 requires that the paperwork accompany the patient on the transport. Another thing that we are encountering quite a bit is hospital systems that engage in proprietary contracts with one ambulance company or another. And when you call that hospital and you say, we want to transfer a patient to you, and they say, okay, but you have to call this ambulance service. EMTALA addresses this issue specifically, and it says that the decision of which ambulance service to use and the level of ambulance service that you use is entirely the decision of the sending physician, because that physician has personally met and assessed that patient, and they are in the best position to make that decision. And the citation is right here for you as well. Another thing you should be aware of is that ambulances are assumed necessary if we're going to an emergency department, but if we are taking the patient anywhere else, that use of an ambulance has to be certified. You have to have a statement of medical necessity for why the ambulance is necessary. And that form is called a physician certification statement. And here's an example of one. Different hospitals have their own versions. Different ambulance services have their own versions. But what it all boils down to is you, as an RN, need to testify on paper that the only way to get this patient from point A to point B is by using an ambulance. In fact, that is the very first sentence on this form right up here. When you sign this form, you're signing a federal document. Another thing that you should understand about EMS is our focus. We are a very short time frame service. You call us, we get there, we find out what the emergency situation is, we stabilize and intervene as necessary, but our priority is to transport that patient to definitive care. That means that there are some things that we don't have very high on our list of priorities that might be more important to you working in a hospital or a skilled nursing facility or some other medical facility. So we don't ask some questions because it's not important to the current emergency. Probably the most important thing for you to understand about EMS is how independently we operate. The entire idea behind EMS is you can send us out to an emergency knowing nothing about what's going on with that patient, and whatever it is we see when we walk in the door, we will just deal with it. It might be paged out as a pain in the leg, and you get there and you find they're having a respiratory emergency. It gets paged out as a minor injury, and it turns out it's a major trauma. Whatever it is, when we get there, we'll deal with it. Because we deal with a lot of emergency situations, we don't have time to consult with a doctor on every call. So when we walk in the door, we're prepared to do whatever it is we think needs to be done for that patient, and all our interventions are almost exclusively based on standing orders. At LifeStar, we are transitioning to a new set of protocols in which 100% of our interventions and medications are standing order based. Then finally, in the miscellaneous category, just a few more things you should know about EMS. Our sense of humor is pretty dark. You can imagine the things we see on a daily basis, and going from minor call to incredibly tragic major call and back to minor call, having to work a cardiac arrest, tell a husband or wife that their spouse of 30, 40 years has died, and then go immediately to lunch. We have developed coping mechanisms in order to deal with that, and our sense of humor is part of those coping mechanisms. Nursing humor tends to be pretty dark too, so the jokes that we tell you understand, and the jokes that you tell we understand. So this is something we have in common. Another thing about EMS is it tends to take a very serious toll on our backs and on our hearts. When we pick up a patient, we like to joke that the only place a patient ever falls is between the toilet and the bathtub on the third floor in a walk-up last door on the left, and to maneuver that patient around and getting them downstairs and out to the ambulance takes a lot of physical exertion. And so when we take a couple extra seconds to call for a lift assist or to prepare for lifting this patient and the maneuvering we're going to have to do, we're doing that to protect our backs, because the number one career-ending injury in EMS is a back injury. It also takes a pretty serious toll on our hearts. Imagine being sound asleep in your bed at the station, the pager goes off, and 45 seconds later, you're driving lights and sirens down the road to a serious medical emergency. The amount of catecholamines that get released into your system, the flight or fight response, just shreds our cardiovascular system. And so the number one cause of death among fire and EMS is sudden cardiac arrest. That's the toll that we pay for the job that we do. Finally, we got to admit that EMS tends to take itself a little too seriously. It is true that we are the ones that get called whenever there's a problem and nobody knows who else to call. It is true that any call we get can turn into a major serious event. It's also true that most of what we do is relatively benign. Most calls for service are relatively routine. And we also point out to new EMTs and paramedics that the overwhelming majority of our patients are going to survive their encounter with us no matter what we do with that patient. So all these drugs and interventions and procedures that are at our disposal, we use them when necessary, but we should not be viewing ourselves as ER physicians on wheels or emergency departments that drive at 70 miles an hour, or all those bumper stickers and memes that you might see in EMS groups. We should probably lighten up a bit. So when we walk in the door and we're taking ourselves too seriously, as long as you're not calling us an ambulance driver, it's perfectly appropriate for you to remind us that we are not all that every once in a while. It's probably good for us. That's the end of my list. I'm sure you can think of other things that are major differences between EMS and nursing and might lead to greater understanding, but these are the things that come up time and time again when I'm working on an ambulance, and I thought it'd be worth talking about. I appreciate you joining me, and I will see you on the next one.